Moving forward towards the case, a 30-year-old man with hypertension, alcoholic church abuser, presented with drowsiness, fever, and abdominal pain for 2 to 3 weeks. MRI brain was done for drowsiness, which shows multiple lacunar infarcts in frontal lobe, thalamus, basal ganglia, pons, and corpus callosum. After which autoimmune workup was done, which revealed positive ANA, anti-dsDNA, anti-cardiolipin, IgG, and lupus anticoagulant, which were suggestive of SLE/vasculitis. CT abdomen was done for abdominal pain, which revealed enteritis along with multiple enlarged lymph nodes. Then the biopsy of lymph node was done, which revealed TB lymphadenitis. He was discharged on ATT. After 2 weeks, the patient again presented with fever, which was persistent since the time of discharge. Clinical examination revealed bilateral basal crepitation. ECG and transthoracic echocardiography were done, which are as follows. This is the ECG of this patient, in which we can appreciate that there is a LVH and LVG strain type of pattern, which are suggestive of some sort of cardiomyopathy, especially hypertrophic cardiomyopathy. These are the transthoracic echocardiographic images. This is the parasternal long axis view, in which we can appreciate the marked hypertrophy of the septum and the posterior wall, which were measured to be 20 millimeter each. When we zoom the image of parasternal long axis view at the mitral valve, we can appreciate that mitral valve leaflets are not normal. They are abnormally thickened, irregular shape, maybe some sort of vegetation present with them, but not very much clear. When we apply color Doppler across the mitral valve, we can appreciate that there is a significant mitral regurgitation. Then these are the parasternal short axis view, in which we can appreciate the marked hypertrophy of the LV, concentric type of hypertrophy, and LV function seems to be preserved. Then these are the apical images, in which we can again appreciate marked hypertrophy of the LV and preserved LV function, LV systolic function. Then when we apply the color Doppler across the mitral valve, we can appreciate moderate type of mitral regurgitation, which was confirmed on the continuous wave Doppler. Then when we apply the pulse wave Doppler across the mitral inflow, we can appreciate pseudo-normalization of ENA with reduced E prime, which was suggestive of grade 2 diastolic dysfunction. Now this image is very interesting, that this is the global longitudinal strain image, in which the GLS is significantly reduced at the basal and mid level with relative sparing of the apex. Apex is spared. This is very interesting. Usually the apical sparing pattern on the GLS is suggestive of amyloidosis. Then we will see what happened in this patient. So our differential diagnosis after the transthoracic echocardiography are severe LVH, maybe secondary to hypertrophic cardiomyopathy or cardiac amyloid because of the apical sparing pattern on the GLS. Then there are thickened mitral valve, maybe some sort of vegetation present on it, but not very much clear. Then moderate mitral regurgitation. Multiple blood cultures were done, which were all negative. Then transesophageal echocardiography was done to rule out vegetation, and these are the transesophageal echocardiographic image. This is a 4-chamber view of the TE. Now, if you can appreciate that only the tips of both the leaflets of mitral valve are thickened, not the whole leaflets, only the tips are thickened, which is more clear in this image. This is the long axis view, that only the tips of the mitral valve are thickened, while rest of the body of the leaflets are normal. I have taken multiple frame views to show it more precisely, that only the tips of the mitral valve leaflets are thickened, while the other parts of the leaflets are not thickened. Then when we apply the color Doppler across the mitral valve, we can appreciate that there is a moderate type of mitral regurgitation. Then aortic valve was normal. There is no thickening of the aortic valve, no significant aortic regurgitation or aortic stenosis. And there is a trace type of tricuspid regurgitation. Then CMR was also done to look for the reason of left ventricular hypertrophy. And these are the CMR images. This is the cine images of CMR. This is a 4-chamber view. This is a 2-chamber view, in which now again we can appreciate the marked hypertrophy of the LV and preserved type of LV function. Now again we can appreciate that the leaflets tips of both the leaflets are thickened, while rest of the part of the leaflets are not thickened. This is more clear in this view, that only the tips of both the leaflets are irregular shape and thickened, but rest of the parts of the leaflets are normal. It is suggestive of Liebman-Sack endocarditis. This is the short axis view of the LV at different levels. We can appreciate marked hypertrophy and normal LV systolic function. This is the early GAT images. In early GAT images, again we can appreciate that these tips of the mitral valve leaflets are thickened. Then this is the late GAT image of the LV, in which we can appreciate the patchy hyper enhancement of the LV, overall patchy hyper enhancement of LV, which is suggestive of hypertrophic cardiomyopathy, not the amyloidosis. These are again late GAT images. Now focus on this mitral valve, that their tips are hyper enhancing. Tips are hyper enhancing in late GAT images as well. So what are our diagnosis after all these investigations? It's SLE/vasculitis, Liebman-Sack endocarditis, hypertrophic cardiomyopathy, and TB lymphadenitis. Wow, all 4 things in a single patient at a single time. It is very difficult to diagnose these things. What was the follow-up of the patient? Patient was started, which was started on ATT previously, was continued. Due to suspicion of Liebman-Sack endocarditis and autoimmune vasculitis, IV methylprednisolone 1 gram OD was started with significant improvement in clinical condition. The fever of the patient has settled and patient improves clinically very much. And then the patient was switched to oral prednisolone after 3 days. Patient was doing well on a clinical follow-up. Regarding this case, I have done a bit of literature search and I found very few case reports which were a bit similar to our case, not exactly related to our case. The first case, which was published in Journal of Thoracocardiovascular Surgery in 2020, in which there were patients with hypertrophic obstructive cardiomyopathy with mitral regurgitation in Liebman-Sack endocarditis. In this case, they have obstructive hypertrophic cardiomyopathy, while in our case, patient was having non-obstructive hypertrophic cardiomyopathy. But they have similar type of thing, and their patient went for ventricular myomectomy and mitral valve replacement for severe mitral regurgitation due to Liebman-Sack endocarditis. Then there is another case report which was published in the Japanese journal, in which patient was having SLE with nephrotic syndrome and they is having a asymmetric hypertrophy of the septum, which is more prominent at the apex. Then this is a case series which was published in Journal of Rheumatology way back in 1992. They have 2 patients, one with SLE, other is SLE-like disease, and they have found the hypertrophy of the septum and ventricular hypertrophy associated with SLE. It was the first time that these concordant diagnoses were established. So, a single slide regarding the Liebman-Sack endocarditis and role of CMR. CMR sequence can show small, irregular, isointense or slightly hyperintense masses attached to the ventricular or atrial side of affected leaflets. CMR helps in defining the exact size and tissue characterization of suspected thickening /vegetation. Thickening on mitral valve may show increased signals in T2 weighted image and also show late gadolinium hyperenhancement. So in conclusion, I can say that the multimodality imaging is very, very important, especially in complex patient when there is a diagnosis unclear. Especially the role of CMR is very, very important to diagnose these patients correctly and guide the therapeutic decisions. Thank you.